Welcome back, viewers. Today's topic, we shall be talking about infertility. Mostly we shall be concentrating on the causes and then the assessment. Once again, I'm Dr. Mamza Joseph. I'm a gynecologist. I'm also a fertility specialist and a laparoscopist. So, what is infertility? First of all, I want us to look at infertility in terms of a couple. I don't want us to look at individuals, but let's look at a couple. So infertility, when we define it, it's basically the failure to conceive after 1 year of regular unprotected intercourse. We are talking about regular intercourse. This is about 3 times at least in every 5 days. That's how regular we are talking about. And it is unprotected. So infertility, we classify it into 2 groups. We have primary infertility, where the couple has never achieved their first pregnancy. And then we have secondary infertility, where the couple has previously conceived, but now they are finding it a little bit difficult to achieve their subsequent pregnancy. So, when do you need to start investigating a couple? For us to understand that, there are a few things we shall need to recollect. One is what we call fecundability. Now, fecundability, this is the probability of achieving a pregnancy in 1 menstrual cycle. The fecundability is usually about 20 to 22%. Then we have what we call fecundity. Fecundity, on the other hand, is the probability of achieving a live birth still in 1 menstrual cycle. So, but importantly, we want to understand fecundability. So, what it means is that if you get 100 women who are normal, no nothing, of those 100 women, within 1 cycle, only 20 or 22 are able to conceive. That's what fecundability means. The fecundability rate of a woman increases every month, every cycle, such that by the time we reach 12 months, usually it is about 90%. So that's why we only investigate couples after they have tried to conceive for 12 months and they have not achieved a pregnancy. However, if the woman is above 35 years, we don't normally wait for all the 12 months. That couple is investigated a little bit earlier. Why? Because we know as the woman grows old, also the ovarian reserve comes down. As she grows older, her fecundability also decreases. So for a couple which is below 35 years, especially for a woman, we normally wait for 12 months before we step in. But if a woman is above 35 years, that may call for earlier investigations. So, for us to understand the causes and how to investigate the causes of infertility, we need to understand first how is a pregnancy achieved. So, for a couple to achieve a pregnancy, first, we need production of mature gametes. Mature gametes, I'm talking about a mature egg from the woman and a mature sperm from the man. Secondly, we need transportation of these gametes from where they are produced to the site of fertilization. In this case, for a woman, I'm talking about we need the tube to transport the egg. We need the man's ducts to transport the sperms from the testis up to the fallopian tube, the ampulla region where fertilization takes place. Then, thirdly, after fertilization, we need transportation of this newly formed baby, the embryo, from the ampulla region where fertilization happened to the womb, which is the uterus. So, if all those processes are okay, we shall get a pregnancy. But any disturbance along those lines will either give us delay to conceive or infertility. So, investigating the causes of infertility, there are landmarks we look at, especially for a woman. One is the vagina, 2 is the cervix, 3 is the uterus, 4 are the tubes, and 5 are the ovaries, which are the eggs. So, for us to really understand the woman's behavior and everything that happens with fertility, we need to understand a woman's menstrual cycle. And we shall highlight that in our subsequent series. So, what we know is that a menstrual cycle can range between 21 to 35 days. We normally take 28 as the average, but not every woman has a 28-day cycle. Some have 21, some have 22, some have 25, some have 30, and some have 35. 28 is the average. So for a woman with a 28-day cycle, most of the time, ovulation usually happens on her 14th day of the cycle. How to count up to your 14th day is the first day you see blood. That is day 1, 2, 3, 4, 5, 6, up to 14. 14th day, 28-day cycle, usually that is the time of ovulation. In a woman who is ovulating, what you need to know is that not every period comes with ovulation. The ovary has its cycle, the uterus has its cycle. So, for a woman who has let's say a 35-day cycle, she is not going to ovulate at 14 days. But what we know is that usually ovulation happens 2 weeks before the onset of the period. So if your cycle is 35 days, that means you're going to ovulate around your 21st day of the cycle. If your cycle is, let's say, 30 days, that means your ovulation day is on the 16th day of the cycle. That one you have to understand it. So, Where can it go wrong in terms of achieving a pregnancy? What we need to know is that 10 to 15% of the couples will struggle to conceive. Of all the causes, the women account for 35%, the men equally account also for 35%. The 20% is shared. You find there is a cause on the female side and also a cause on the man's side. Then the 10%, we classify them as unexplained infertility. We have investigated them. They all seem okay, but still they are not achieving a pregnancy. We classify them as unexplained infertility. So, looking at the factors and seeing that both sexes actually take an equal share, what can go wrong to cause infertility? Let's start on the men's side. Investigations for a man are a little bit simpler and fewer compared to a woman. For a man, what we need are sperms. Either the problem is you're producing insufficient sperms, or the sperms are abnormal, or the sperms are actually completely absent. So we tend to classify the causes of the male infertility either pretestitular, where we say the cause is before reaching the testis. This can be environmental factors like in the workplace. Let's say you're exposed to radiation. There are other factors like maybe alcohol intake, excessive smoking, and drug use. Those we call them pretestitular. Then we have testicular causes, where the problem is within the testis itself, because it is the testis that makes the sperms. The common causes: infections, mumps, otitis, the common one. Then we have structural anomalies, abnormalities. There's what we call varicocele. Varicocele, these are swollen blood vessels which accumulate a lot of blood within the testis. We know that sperms are manufactured at a specific temperature. Disturb it and you will have nothing. So with varicocele, you have all this accumulated blood. Blood comes with change in the temperature, and that will lead to low sperm production or even nothing. Then we have post-testicular causes, where the problem is outside the testis. The testes have done their work, they have produced, but maybe the ducts are not transporting what is being produced. So that is how we classify the woman's causes. So a semen analysis will give us the direction, whether we go ahead and do some hormone assays on you or not. However, it should be noted that one semen analysis is not conclusive to say that this is it. So most of the time we tend to do subsequent, at least 2, to get a picture. That is on the man's side. So for a woman, looking at a woman, I want us to look at a woman in these different landmarks: the vagina, the cervix, the uterus, the tubes, the ovaries. Starting with the ovaries, what we need from the ovary is an egg, what we call ovulation. So, how do you know that you're actually ovulating or not? One, regularity of the cycle. If you've been having regular cycles for the past 6 months, that is enough indicator that you could actually be ovulating, although it's not 100%. Secondly, there is what we call the symptoms to follow, symptothermal methods. One is that during ovulation, there is a little bit of elevation in your body temperature. So if you're observant enough, you will actually feel it. Then there is also change in the consistency of the mucus that is released from your cervix that comes out through the vagina. So if you're attentive enough, you're able to pick up these signs yourself without need of a doctor. Then there's what we call the ovulation kits, the LH predictor kits. These are like urine pregnancy tests, but in this case they are testing for another hormone, LH, for ovulation. What we know is that LH normally spikes 24 hours before ovulation happens. We call it the LH surge. So if you have your LH urine kit and you test and it is positive, what that means is that within the next 24 to 36 hours, you are going to be ovulating. So those are some of the simple tests. However, when we go to the lab, we can also test for ovulation. Because we know after ovulation, this egg has come from a shell. This shell is called the corpus luteum. So that corpus luteum starts producing a hormone, the hormone called progesterone. So if you're to measure it, usually we take the 21-day progesterone. It is able to tell you if you actually ovulated during your cycle. So that is the ovary. Then, with the ovary, we can also test for ovarian reserve. How much egg is left and what is the quality of it. So, one of the tests is called the anti-Mullerian hormone. This can be done any day of the cycle. Whether you're in your periods, whether you've finished, whether you're ovulating, it can be done. Then we have another hormone called FSH, follicle stimulating hormone, produced in the brain. This one, we do it on specific days of the cycle. Its job is usually to make the eggs grow. So if your ovarian reserve is normal, is okay, then you don't need a lot of follicle stimulating hormone to make your eggs to grow. But if your ovarian reserve is very low, then you will need a lot of follicle stimulating hormone to get a chance of making one follicle grow. So in ladies with a low ovarian reserve, you find the FSH is a little bit elevated. And those with a normal ovarian reserve, the FSH is usually within the normal ranges. So that is to do with the ovaries. Ovaries, what we need is ovulation. What can cause you not to ovulate? The common one is what we call polycystic ovarian syndrome, especially in the young couples. We highlighted it in one of our series, so you can look it up. Then there are other causes. Physiological stress. Stress causes an elevation of a hormone called prolactin. As long as your prolactin is up, you will not ovulate. That's how breastfeeding protects mothers from pregnancy in the first months. However, we can have prolactin increasing from other causes, not just physiological stress. We may have what we call prolactinomas, also secreting a lot of prolactin and causing you not to ovulate. The other causes is if there are any problems to do with your thyroid gland, the gland here, especially with hypothyroidism. So that is to do with the ovaries. Once we've checked your ovaries and they are okay, we've checked the man's sperms and they are okay. So that means the problem could be in the transport of these gametes to the place of fertilization. So the next place we look at are your tubes. Tubes, very hard to see on scan unless they are maybe swollen with what we call extensive hydrosalpinx or pyosalpinx. So tubes, we don't assess them with a scan. There's a special test we do, it's called a hysterosalpingogram. It's usually done on day 10 of your cycle. So it highlights all the way from the cervix through your uterus and your tubes. So if the tubes are open or closed, we shall know. However, it's not 100% sensitive. It can give you false positives and false negatives. The confirmatory test is usually with what we call a laparoscopic dye test. Although the problem with it is a little bit invasive and a little bit more costly in our setting, so we tend to go with the hysterosalpingogram. And this is how ideally the hysterosalpingogram looks like. So after assessment of the tubes, the next thing to look at is the womb for the woman. So either the womb has what we call structural abnormalities, which you were born with. Either you have what we call a conjugate arcuate uterus, double uterus, or you have a septum, or you even have an absent uterus. So those are structural abnormalities, the ones you are born with. Then we have the acquired. Either you have significant fibroids and they are located in a place that wouldn't really favor fertilization or even implantation, or you have what we call adenomyosis. Adenomyosis, that's where you find the uterine muscle is thick. Thick, why? Because during your menstrual cycle, you tend to menstruate. You have what we call endometrium within your uterine muscle, so it keeps swelling. Adenomyosis makes your uterine wall, what we call the endometrium, it makes it unfavorable to receive the baby. So that can also account for what? For infertility. So after looking at the uterus, the next place we look at is your cervix, because the cervix has to allow sperms from the vagina to ascend through it. So you may find the cervix is closed, what we call stenosis, or the cervical mucus actually kills the man's sperms. By the time they are getting up there, they are already dead. Then, after looking at that, the next place to look at is down the vagina. So what would be the problem with the vagina? There is what we call vaginismus, which makes intimacy a little bit difficult for the woman. And then there is endometriosis, especially if it is in the posterior wall. That may make sex also very painful, what we call dyspareunia. So it makes the frequency of the intimacy also a little bit hard. And all that can account for infertility. So, in summary, investigations are tailored to what is the most likely cause, because the investigations are many and some of them are expensive. You may not run them in one day, and some of them are time specific. They have to be done on a specific day of the cycle. So fertility assessment is a stepwise process. It's not a one-day hospital visit and everything is done. So it needs a little bit of patience on your side as the patient, and also patience on the side of the doctors. So male and female all account for equal percentages of the possible causes. Let's not neglect any. Let's not concentrate on the woman and forget on the men. They all take the 35%. So on our next episode, we shall be concentrating on the different treatment options. Thank you.